Hi everyone, today I want to talk about the topic of myotonic dystrophy in medical genetics. Based on the outline of the teacher, we have four main parts in introduction to the disease. The cause of the disease, the diagnostic method and treatment, and finally a new method. In the main sections, I have added extra parts to help us better understand this disease. Let's get started. First, myotonic dystrophy is a long-term genetic disorder that affects muscle function. This is a disease, autosomal dominantly inherited with genetic anticipation. DM causes general weakness, usually beginning in the outside muscles. It slowly progresses to involve other muscle groups, including the heart. DM affects a wide variety of other organ systems as well. As you can see by the picture, the muscles in the patient tend to shrink over time compared to the average person. Here are some pictures of people with this disease in the world. It affects more than 1 in 8,000 people worldwide and 140,000 people in the United States alone. In particular, this disease can occur in children with a rate recorded in Japan as 1/1,000th or 3 to 15 per 100,000 in Europe. People with myotonic dystrophy usually have stretch muscle tensing, myotonia, and are not able to relax certain muscles after use. For example, a person may have difficulty releasing their grip on a doorknob or handle, or the failure of spontaneous release of the hands following strong handshakes due to myotonia, delayed relaxation of muscles after contraction, which accompanies muscle weakness. Symptoms often include progressive muscle weakness, stiffness, tightness, and wasting. On the other hand, the disease has other symptoms such as slurred speech, temporary locking of their jaw, clotting of the lens of the eye, cataracts, abnormalities of the electrical signals that control the heartbeat, cardiac conduction defects. There is also a tendency for cardiac conduction defects, susceptibility to diabetes mellitus, and risks associated with general anesthesia. Additional clinical features include frontal baldness and gonadal atrophy in males, fatigue, daytime sleepiness, gastrointestinal symptoms, and pigmentary retinopathy. There are two major types of myotonic dystrophy, type 1 and type 2, and the two types may affect different muscles. Their signs and symptoms overlap, although type 2 expanded to be milder than type 1. Type 1 German mark, also known as Steiner disease, has a severe congenital form in a milder childhood onset form as well as an adult onset form. The muscle weakness associated with type 1 particularly affects the lower legs, hands, neck, and face. Type 2 German marks, also known as proximal myotonic myopathy, PROMM, is rarer and generally manifests with milder signs and symptoms than 1 German mark. Muscle weakness in type 2 composed involves the muscles of the neck, shoulders, elbows, and hips. Myotonic dystrophy is a progressive disease, meaning that symptoms worsen as a person gets older. Life expectancy appears to be reduced for people with myotonic dystrophy type 1. The most common causes of death in people with 1 German mark are respiratory and cardiac heart symptoms. In special cases, babies are born with a variation of myotonic dystrophy type 1 called congenital myotonic dystrophy. Symptoms of congenital myotonic dystrophy are present from birth and include weakness of all muscles, breathing problems, club feet, developmental delays, and intellectual disabilities. Myotonic dystrophy is caused by mutations, changes in either the DMPK gene in type 1 or the CNBP/CNF9 gene in type 2. Type 1 German mark. 1 German mark occurs when a gene on chromosome 19 called DMPK contains an abnormally expanded section located close to the regulation region of another gene, SIX5. The protein produced from the DMPK gene may play a role in communication within cells. It appears to be important for the correct functioning of cells in the heart, brain, and skeletal muscles which are used for movement. Type 2 German marks. 2 German marks is caused by an abnormally expanded section in a gene on chromosome 3 called CNF9. 2 German marks was originally called PROMM. For proximal myotonic myopathy, a term that has written in use but is somewhat less common than the term two German marks. The CNBP gene gives the body directions to make a protein found mainly in the cells of the heart and skeletal muscles, where it is thought to regulate the activities of other genes. The specific kinds of mutations found in both types of myotonic dystrophy are trinucleotide repeat expansions. These types of mutations occur when a piece of DNA is abnormally repeated a number of times, which makes the gene unstable. The mutated gene makes an altered version of messenger RNA mRNA, which is a copy of the gene that is normally used for protein production. The abnormal mRNA forms clumps inside the cell that interfere with the production of many proteins. These changes prevent cells in muscles and other tissues from functioning normally, leading to the signs and symptoms of myotonic dystrophy. The genetic basis of DM is an unstable length mutation of a CTG repeat tract within the three untranslated regions UTR of the DMPK gene, and it is therefore one of the conditions in which genetic anticipation is observed. Normal individuals show stable minor length variations of this region, with 4-3-7 CTG repeats exported in DM expansion into the clinically affected range from 50 to over 2,000 repeats is seen. With these larger repeat tracts being unstable, TE phenotypic expression is very variable, and there is a general, but incomplete, correlation between the size of the repeat sequence and the clinical severity. 5099 CTG repeats mild 100 1000. Classic affected in 1000 to 2000. Congenital carriers of small amplifications may have no symptoms. Normal electromyograms and normal slit lamp examinations. Further repeat tract expansion, however, can result in more severely affected offspring, with the chance of a large increase in repeat tract size and transmission being more likely from female carriers. Those female carriers who have DM symptoms or signs may have a congenitally affected floppy infant at risk of neonatal death or severe respiratory problems and subsequent physical and mental disability. Conversely, the length of the mutation may occasionally decrease at transmission, and this is more common for paternal 10% than maternal 3% transmission. For the spring of an affected female, on average 50% are unaffected, 29% are affected in later life, 12% die neonatally, and 9% have severe neonatal hypotonia and significant learning disability. For an affected male, half of his offspring are affected and half are unaffected, with neonatal cases being rare. The mechanism of pathogenicity of the repeat expansion is complex but is currently believed to result from the abnormal DMPK mRNA, which indirectly exerts a toxic intracellular effect on the splicing of other genes such as the chloride channel 1 CLCN1 gene that appears to be responsible for the myotonia. In addition, the expression of genes adjacent to DMPK, such as SIX5 and DMWD, appears to be reduced, possibly due to condensation effects on the chromatin by the expanded repeat tract. Below are a summary of German Quang diagnosis and treatment. The diagnosis may be confirmed with clinical history, tests of muscle function, and genetic testing. Myotonic dystrophy is diagnosed by doing a physical exam. A physical exam can identify the typical pattern of muscle wasting and weakness of the jaw and neck muscles and the presence of myotonia. There is also one test called electromyography (EMG), which involves inserting a small needle into the muscle. The electrical activity of the muscle is studied and usually shows characteristic patterns of myotonic dystrophy. Other laboratory tests may include a muscle biopsy, which can be used to determine if the muscle fibers are recognized and they should be atrophied. The definitive test for myotonic dystrophy is a genetic test. For this test, a blood or saliva sample is analyzed to determine if there are elevated levels of certain muscle enzymes. Affected individuals are advised to undergo regular ECGs to detect conduction defects. blood sugar tests for diabetes mellitus, and assessment of their vision for ocular cataract. Pre-symptomatic carrier detection and prenatal diagnosis are possible by DNA analysis by PCR and occasionally southern blotting for prenatal tests for infants in the womb. This can be done at 10 to 12 weeks gestation by a procedure called chorionic villus sampling, CVS, that involves removing a tiny piece of the placenta and analyzing DNA from its cells. It can also be done by amniocentesis after 14 weeks of gestation by removing a small amount of the amniotic fluid surrounding the baby and analyzing the cells in the fluid. Each of these procedures has a small risk of miscarriage associated with it, and those who are interested in learning more should check with their doctor or genetic counselor. Currently, there is no known cure for this disease worldwide but relies heavily on the signs and symptoms of a patient. Treatment of myotonic dystrophy is by a multidisciplinary team. A neurologist oversees the various needs of the patient and directs care. The neurologist may recommend that myotonia, the inability to relax muscles, be treated with a drug such as maxilladine. An EKG to look at the heart rhythm, and frequently an echocardiogram to look at heart function, will be performed. A test of lung function will also be performed. Depending on the neurologist's findings and results of these tests, a referral to other specialists who also have expertise in myotonic dystrophy, including cardiologists, pulmonologists, and ophthalmologists, will be recommended for additional treatment. Pacemaker insertion may be required for individuals with cardiac conduction abnormalities. Central sleep apnea or obstructive sleep apnea may cause excessive daytime sleepiness, and these individuals should undergo a sleep study. Non-invasive ventilation may be offered if there is an abnormality. Patients are often required to have regular physical activity. There is a lack of high-quality evidence to determine the effectiveness and the safety of physical activities for people who have myotonic dystrophy. The combination of aerobic and strength exercises may increase muscle strength. Aerobic exercise via stationary bicycle with an ergometer may be safe and effective in improving fitness in people with one German mark. The weakened muscles can affect the whole body, so orthotics can be applied. Muscular weakness of dorsiflexors, dorsiflexion, hinders the ability to clear the floor during the swing phase of gait, and people may adopt a step hitch gait pattern or ankle foot orthotics may be indicated. Factors such as hand function, skin integrity, and comfort must be assessed prior to prescription. Neck braces can also be prescribed for neck muscle weakness. In addition, assistive devices are also created to assist patients in performing the functions of their organs. Upper and lower limb weakness. Visual impairments and myotonia may lead to the need for mobility aids and functional adaptive equipment such as button hooks and handled sponges for optimal hand function. Based on the cause of the disease, myotonic dystrophy occurs due to the repeated trinucleotide CTG of a segment of the DMPK and CBNP genes, repeatedly making the genome stable. These abnormal segments are transcribed into a modified version of mRNA. In my opinion, one of the methods used to treat this disease based on the cause of the disease is the application of gene editing techniques. The current gene editing method in the world is the CRISPR technique, with a complete removal of unwanted genes from the human body. Scientists can apply this method to myotonic dystrophy to remove DMPK or CBNP from the human body at an early stage, because the late application can cause abnormal CTG segment to repeat many times. The length of the segment genes that need cutting will be very large. On the other hand, mRNAs, after undergoing transcription processes, interfere with the production of many proteins. Therefore, scientists should consider removing these mRNAs from the human body by the control of mRNA decapping and P-body formation. That's all. Thanks for watching.